Welcome, everybody. We're very glad to be here. I'm just going to say a few words and then we'll turn it over to Dylan. He and I have been working together with our colleagues at the Institute for Healthcare Improvement. And what we really want to share today is, how we do this work with many of you in the real world. The work that we're talking about today is how we take some of the research that many of you are in the middle of or you've done in the past, really important research, and build on that, but also how we bring it from the research setting into real world settings and think about scale and spread. So a lot of what you're going to hear us talk about today is about implementation science and how we do scale and spread, going from what we know in a more controlled environment, as many of you are working in those environments, to broader and deeper initiation and implementation in various settings. In particular, we're going to focus on payers as well as providers, because that's kind of the trajectory of our work, has been going from focusing specifically on health systems, different settings within those systems, to thinking, well, turns out that the payers have a role in this as well. And a lot of this is through a team at IHI called Age-Friendly Health Systems that Dylan and I are both on. Some of you may have heard about Age-Friendly Health Systems. We have about 2,900 systems around the country and globally participating. We've also done work in nursing homes, as Janet mentioned, currently leading the Moving Forward Nursing Home Quality Coalition. I'll chat in that website if you're interested. We worked on Project Echo, and Dylan works with CVS and a number of our other work that we do with IHI. So I just want to say, Dylan is just an amazing thinker about these things. He really comes up with terrific ideas and innovations that I would not have thought about. So it's very fitting that he's going to be going through our slides today that, we work on together, and then we'll be happy to do questions and answers at the end. We really hope to hear from you. So I'll monitor the chat. I'll watch. If you want to chat in anything during the presentation, please do. So with that, Dylan, I think I'm turning it over to you.
You're muted.
Thank you to whoever said that. Hello, everyone. Wouldn't be a Zoom meeting if there wasn't someone talking on mute. Very excited to have you all here today and to be joining you all. Couple notes before I dive into my slides. I really love questions, especially ones that we don't have answers to yet. So as I'm going along, please chat them in. We will certainly have time at the end to answer them, and would love to hear from you all in the process. Great. So today I'm going to give an introduction to the Age-Friendly Health Systems movement, if you're not familiar, talk a little bit about the ongoing projects that Alice and I are leading with our partners, analyzing the payer space, and then I'll move on to some other levers for consideration. So as Alice mentioned, we are quickly approaching 2,900 health systems. I pulled the numbers today, and we've crossed 800 as well. These two designations have different bars to entry for our partners. We like to keep at IHI the bar to entry low and lower barriers to accessing improved care. So participants are sites that have explained or enumerated how they would provide age-friendly care. Age-friendly care for us is determined by the set of 4 M's: what matters, medication, mentation, and mobility. It's really key that these are delivered as a set, as they are interdependent on each other. So health systems that are designated as committed to care excellence provide a set of data for us showing the spread of the 4 M's in their settings as well as outcomes. So it's the first you could imagine as a process measure, whereas the second you could imagine as an outcomes measure. So up to date, our primary method for scale and spread of the age-friendly model has been through action communities. These are a 7-month learning collaborative, many of which hosted by ourselves or hosted by some of our partner institutions like AHA, CHA, and some state-level health associations as well. We're also moving into partnerships with unique to settings. So we are launching an action community unique to cancer centers, as well as some other nursing home and other centers or settings of care as well. So the age-friendly movement began in 2016. and has been evolved over that time. Our work primarily focused on health systems and providers, trying to train them and bring them along. And now that as we've continued to move across adoption and uptake, we're beginning to look at other settings of care and other methods for promoting the uptake of age-friendly care. So the one that Alice and I most focus on are payment and regulation. We view these as key players in the space to try to move beyond just the patient and provider. But there are a number of other levers that we focus on as well. We have emerging work with information technology in electronic health records. We have a really robust relationship with Epic and are moving towards building the 4Ms into their base product for all health systems. More to come on that in the future. We also are working in the certification space as well, working with the Joint Commission and NCQA to think about how measurement and certification of health systems can help with the uptake of the 4Ms. So within the age-friendly umbrella, as we like to put it, these 5 buckets fall under the macro environment. And that is the environment beyond the patient and provider that can help and influence the care that they receive. So as we mentioned, regulation, certification, accreditation, health plans and payers, and health information technology. These are the 5 buckets that we really focus on in as we're moving into this next phase of our grant, doing exploratory work to understand how we can build these relationships and build sustainability into our intervention. As I'm sure many of you in your own spaces understand, when you're doing grant-funded work, sustainability is a really key piece because eventually that funding changes and you want this to have longevity and impact beyond the life of the grant. So moving into our ongoing projects, we've had a focus in our first 9 months of this work on 2 buckets, specifically traditional fee-for-service Medicare, as you'd imagine from CMS, as well as work with payers that are in the Medicare Advantage space. So focusing first on our partnership with the Center for Healthcare Strategies. This was our project to better understand traditional fee-for-service Medicare and the levers that exist for us to promote age-friendly care within it. We outlined a process with them to do key informant interviews that included 20 or so stakeholders from across the industry. More on them on the next slide. But the interviews were very informative for us to understand the current state and the current knowledge around age-friendly health systems, as well as other initiatives for aging in this space. We also convened an expert roundtable to talk through some of our ideas for adoption and integration. That was happened in August, and it was a very, very, as one person described it, it was a family reunion in a way of people across industry coming together and really thinking about these issues in a very active way to try to come up with proactive solutions. So coming out of this work, we have some summary memos that have collected the themes along the way. And we're also producing 2 policy briefs that will be public facing. More on them to come in the next few slides, but really important for us that we're making accessible and attainable information for our partner sites and our health system sites to be able to take these learnings to the ground quickly. So who did we interview? We had relationships with federal agencies, specifically CMS and HRSA, to try to understand this from the federal perspective. We also work with some legislators and from the House Ways and Means Committee specifically to understand how legislation and the law can influence this, and if there are gaps or if there are other areas for us to be focusing on. We also leverage our relationships with national associations, some health researchers, as well as a number of ACOs and other care settings that utilize fee-for-service Medicare the most. So coming out of the interviews, we had some variable understanding of the age-friendly health systems movement, but also some clear opportunities to move forward. Education is with any movement of this kind where you're trying to make care better. Education is key, especially education across audiences. To date, most of our educational resources have focused on the provider, which has had a value as we've gotten to our first 2,900 health systems. But as we continue to grow, we have to diversify our set of educational materials. That includes education for the patient and bringing them along in the process, as well as provider and site-specific educations. Through my work with CBS, I've learned very quickly that an NP working in, say, an emergency room or at a traditional hospital needs very different training than an NP that works at a convenient care clinic. You know, there's no longer relationships of care, and there's barriers to building that relationship with an older adult. So some of those learnings are really key here as we think about how we continue to grow beyond our first 2,900 sites. We also found that alignment is a key for success in trying to move this forward. The federal space has had some shifts in the recent years around this topic. As it was alluded to earlier, there was a nursing home report. There's been a focus on the federal level for this, the care of older adults and nursing home care. So how can we, using our model, leverage existing models that have been taken up in other locations to advance the care for all? And then lastly, one key identification was the enhancement of the 4Ms and quality measures. We have a really robust relationship with NCQA and other measurement organizations, but trying to bridge that gap, and even though there is evidence of these outcomes, really making sure that if we can tie these outcomes and these our bucket of care with quality measures, that can help drive better reimbursement for providers, and also provide better care to the patients in the process. So our roundtable included some of the people from our interviews, as well as other members, including the Institute for Accountable Care and Leading Age. This was, as I said, a very active conversation where working through these topics proactively, trying to think of solutions. The 5 themes are listed on the right here. Again, education and awareness. We focus on the alignment with existing models. Equity is a very key piece. Health equity is becoming more and more broad in this field and important in this field. So trying to find a space for that was important. Again, measurement and quality, and then alignment with federal policies. The roundtable was very key in informing our next steps of this work. We're moving into a new grant next year, and so trying to understand what relationships and what appetite for working together existed was key for us to set up our next year of planning. And then, as I mentioned before, we're developing 2 policy briefs to the public audience. We ended up deciding on the ACO model and annual wellness visits as the 2 focuses. They both relate to the 5 key themes, as I mentioned before. One important one to note, I think, is equity. On both for ACOs and for annual wellness visits, there's evidence of discrepancy within equity. And so the age-friendly model, having been shown to be equitable, could help close some of those gaps. There's also impacts on billing, and the training of providers that will be reflected here as well. So we're excited to have those come out this fall and be able to continue to bolster our place with ACOs and annual wellness visits, as there are 2 key levers on the federal side of things that we can have movement with. The second ongoing project I'll talk about is our work in the Medicare Advantage space. So we partnered with Collaborative Consulting. They're a firm out of California with great experience in this space. And again, trying to understand how we can fuel adoption and integration of the 4Ms, working with Medicare Advantage plans. A little bit of a candid note here. The working with Medicare Advantage plans and payers in general is something new for IHI. So that was one reason why we chose to partner with other organizations who had more experience with them to try to better understand this. And we couldn't be happier with our relationships that we forged with CHCS and Collaborative Consulting alike. And they've very much informed or helped us inform our plan forward when it comes to Medicare Advantage plans. So we took a similar process here where we did key informant interviews with stakeholders. Again, there was a few dozen interviews, and the end goal here was a business case. One member of the Collaborative Consulting team, Victor Tabouche, he was instrumental in us developing our return on investment calculators for inpatient and ambulatory settings. So those are available on our website and have been, the field has relayed that those are very important tools for them. And so we wanted to begin to replicate this for the Medicare Advantage space, knowing that this is a way to help show or to help secure buy-in from partner organizations. And again, some of the key deliverables coming out of this were a Medicare Advantage primer, some summary memos, and then the business case that we will show you some about in a few slides. So the primer was, as I mentioned, this was a novel space for IHI. So we really wanted to make sure that we were understanding the language and the ways that Medicare Advantage plans and payers more broadly operate. There's a lot of considerations around risk models and plan types, nonprofit versus for-profit plans, as well as supplemental benefits in SNP plans. So this trying to better understand these was really important for us, especially while Alice and I might be really engrossed in this work and really understand it. Thinking about sustainability again, how can we make sure that other projects or other members on our team can be set up for success when working in these spaces? And then also just making sure we understood the differences in payment structure and how that relates to measures, as we mentioned with some of the CHCS work, wanting to drive better reimbursement by measures and ratings. So the interviews, we had a smaller set of groups. It was much more focused on leadership from MA plans. So there were a number of plans that we worked with, including nonprofit and for-profit MA plans, trying to understand the leadership perspectives around engaging with this work and trying to drive it forward. It was really important for us to include chief financial officers as well as chief medical officers, as some of you may have experience in your own rights, being more of a clinician or more being on the leadership side of things. There can be some discrepancies when it comes to leadership views and priorities. So making sure that we had diversified in leadership roles was important for us. We also work with Veteran Affairs. We have a robust relationship through the Age-Friendly Health Systems movement with the VA. And so working with them and making sure they were reflected here was very important. We also interviewed a number of physicians and experts in health equity. Again, health equity is just becoming more and more prevalent, and we wanted to make sure that we're building that deeper and deeper into our work by design. So some of the early learnings from this space was the real impact of risk structure on the willingness to adopt age-friendly and the 4Ms. There are nonprofit plans or mission-driven plans are much more willing to engage with this, not to use the word again, but they by design are have more flexibility to explore this work. A lot of for-profit plans will have much tighter timelines, whether it be 90 days or 6 months for implementation of this type of work. Whereas we've learned through these interviews that mission-driven plans have much more flexible timelines for adoption and don't need to see that return on investment as quickly. So not that we don't have a return on investment with our work, but just knowing the nature of this, and it can take time for some of these to come to fruition. We also found the value in special needs plans and their supplemental benefits to be better aligned for this work. So that's another area that we're focusing on moving forward. And then lastly, again, the annual wellness visit is another area that bubbled up in this work as well as a key area for integration, given its tie to payment, but also given the structure that it has. The 4Ms really lend well to some of the conversations and the care planning that's supposed to occur during an annual wellness visit. So aligning there is a key area for us moving forward. So then our final business case kind of found 4 driving factors that influence the payment and the return on investment for Medicare Advantage plans. First is attraction, being age-friendly now, especially that there is patient awareness and patient desire for age-friendly is viewed as a very attractive piece to older adults. So this can certainly drive a return on investment by attracting new members while also helping retain members that may have naturally been lost to churn within the plan. Similarly, given that there is this patient desire that we're building for age-friendly, this certainly helps drive the return on investment for our payers there. Additionally, age-friendly care and the 4Ms are associated with cost reduction through prevention. So this is another really important piece for us to build out outcomes around and to show to providers. And lastly, the impact that the 4Ms have on measurement can drive bonus payments, namely star ratings and others as well. And now thinking about our next steps of work, you'll see this graph on the right that has higher impact in ease as a scale. But these are 4 key buckets that we're looking to drive forward. First being developing communication strategies to target MA plans. As I've mentioned, there's such variability when it comes to plan risk and plan design. So trying to understand the differences among them so that way we can tailor our messaging and use the most effective interventions when working with them. If it's that's very important for us. Well, if it's a mission-driven plan that has a longer timeline for adoption, we can do some of this longer, harder work for integration as opposed to a for-profit plan that needs to see the impact on a much shorter timeline. So we're working now into the next phase of our grant to build out this communication strategy and are excited to put it into action. Next, I call out the develop and deploy an MA plan for readiness. Readiness and ability tools are not uncommon for any area of work. They're really important, especially as you move past the early adopters and into more of the bigger majorities of people. So trying to understand what that would take and what exists in an MA plan already, given that there is such variability among MA plans, helping MA plans see what they do already that is age-friendly and bolstering that success. Next, you'll see the testing age-friendly in MA contexts. We have a number of levers within the MA plan that we've identified, namely some of the supplemental benefits or care coordination. There are a number of levers that we can engage with and see what age-friendly looks like in those spaces. And so right now we're developing some more relationships with MA plans to move into some of this testing. We're in the very early phases of that as well as we move into this next grant next summer. And then lastly, you'll see develop the capacity building and quality assurance for MA plans. Like a lot of the success that we've had with our action community model for health systems and providers, something of that nature would be beneficial to MA plans as well, whether it be more asynchronous or more educational based. I think it's really important for us, especially given the place that MA plans or payers in general have back towards providers that they contract with. They have additional levers that we don't regarding education and communication. So really trying to capitalize on that and come up with a unique model that works well for MA plans, similar to our action community model for health providers. And then so talking about some of the other levers that fall under this umbrella as we move out of this first phase of work focused on the plans and onto these others. I'll start here with the NCQA. We have had really robust conversations with NCQA to date, trying to explore an age-friendly measure set. There's ongoing work around what matters. And if you're not familiar, what matters is similar to advanced care planning, but it's really not necessarily focused on end of life, but more on driving what the patient wants and centering that at care. So these and the patient-driven outcomes are really key and important and can be adapted to be a broader age-friendly measure set. So we're working out our next steps with them. We had a really robust call on Friday, actually, so it's perfectly timed. But we're moving into the next step to see what it would take to build that out and building that into our next phase of our grant. So more to come in the next few months as we work that out, but excited to have this partnership with them, given the really key impact that measures have on reimbursement for providers and plans alike. We're also considering certification and accreditation. We're working with the Joint Commission, mainly at this point on the educational side of things, trying to bolster the support from their resources, as we also consider what it would mean to integrate the 4Ms into accreditation certification. We also have really great relationships with electronic health records. We work very closely with Epic, and this is very unique because this ask really came from the health systems. So a lot of our partners, Rush, CVS, were really instrumental in opening up those channels to Epic to say that we're doing the 4Ms and this is better care. How can we make this more seamless for everyone? So the working group was convened about a year ago to build out Epic build out the 4Ms into Epic's base product. So actually later this afternoon, Epic is hosting a webinar to update its members on the progress advance of the rollout next year. So we're really excited that they're in their final phases of build out, as this will having the 4Ms as a base product in their base product will only amplify our reach. So really excited about that. We also are partnering with the VA for their as a method to work with Cerner, as they have the federal health record that they're developing. So wanting to also mimic that and try to build the 4Ms into the base product as well. And then some of our adjacent work that just to speak on as well, equity within the 4Ms has been a very important focus of the last few years. We are wrapping up a project with 8 sites to focused on equity in the application of 4Ms and its impact on health disparities. So the sites were spanned the country and spanned setting, but there was really great success in showing that the 4Ms are applied equitably and don't further exacerbate health disparities, but do work to correct them. So more about that once the work finishes later next month. But excited to see the equity further be built into the 4Ms. There's also, we are continuing our work with Rush University Medical Center and their Caregiver Institute out of Chicago. We received funding to continue this work into the second phase of piloting. So Rush has developed a very robust model for caregivers of older adults, trying to have what matters and other interventions for them. And so we did work over the last year with 6 pilot sites, and we're scaling up to 40. So we're going to also be on the IHI side, we'll be boiling down a key set of interventions that we can then work into the age-friendly health systems model to make sure that caregivers of older adults are also accounted for and cared for when in age-friendly systems. We also have our partnership with CVS Minute Clinic. CVS has made the commitment to expand the 4Ms to all of their Minute Clinic, 1,200 Minute Clinic sites across the country. And they are well on their way to do that. They're tracking well for their year 1 goal of 30%. And it's really great to see the impact of a broad coordinated system and with real leadership buy-in, the impact that can have on scale and spread. So just seeing how creatively CVS works, especially given their expansions into home health and with Aetna, seeing the coordination is really key there and a real key learning for us to have leadership buy-in from the start. And then Alice also, it has a bigger hand in some of these next projects, but we have work emerging with the NASEM report and with Davos around Alzheimer's and screenings in primary care. We also are bringing Age-Friendly International. We are working with the Hamad Medical Group out of Qatar. They're modeling similar work with Safer Care Victoria in Australia, where we partner with an organization and set up basically a replicate of age-friendly health systems in another country. So excited to see that the international work is continuing and is only expanding as age-friendly health systems. It should not just be unique to the United States, as older people are aging all over the world.